So you can see the whole image. This is a classical image of an ulcerative colitis patient with the severe disease activity. What you can see is the whole mucosa is completely inflamed. There are a lot of islands of normal looking mucosa. These are the certain islands of small normal looking mucosa. Some looks a bit nodular here and there, maybe because of pseudopolyps and things like that, which are hypertrophic tissues of normal areas. All this while the crevices are all filled with blood and shows nice active ulceration here and there. There are a lot of white patches, which all mentions a sloughed off patch, and there are a lot of ulceration. Without even touching any part, there is spontaneous ooze of blood across the complete mucosa. There is no area of the mucosa which is spared. Almost every area is either inflamed, ulcerated, with spontaneous ooze, with certain areas showing a nodular surface, suggesting a pseudopolypoid formation with a hypertrophic reaction. So in this case, we usually suggest don't proceed any further on passing the scope deep within, trying to find the entire extent of the disease. All those things are completely unnecessary. So skip the entire part and come back to the square one of taking a biopsy, mainly to rule out a associated CMV infection. Yeah, a CMV infection is something like a viral inclusion body will be present in these tissues when on histopathology, not on clinical basis. And that's something which will need IV antivirals to avoid a disseminated infection in case of a CMV. So when we took a histopathology, and this is the slide which we got it, all the sections are showing, these are the sections of the crypts, and the distortion of the crypts is very clearly noted with a lot of neutrophilic infiltrates, and there are a lot of lymphoid aggregates here and there. All this suggestive of a very clear cut, a severe ulcerative colitis condition. Yeah. So a complete diagnosis in this state is a severe ulcerative colitis, and what we are suspecting is a natural aggressive course of the disease rather than a superadded infection where we didn't find any viral inclusion bodies and things like that. And our blood counts clearly showed the infection part is not much obvious. The CRP, elevated ESR, shows again a natural course of a flare of the disease. Yeah. So this image should be stuck in everybody's mind when it comes to a severe ulcerative colitis. So what do you do next? The question is, you've diagnosed, you've treated, you've already seen a patient, but always these patients in a severe flare of disease, hydrocortisone is the first rescue therapy in a country like India. So we started this patient on an IV hydrocortisone, 6-thali, along with azathioprine, which is already on, and we continued this in. And systemic and oral mesalamine was started, which is oral and enema preparations. We gave 1 unit of blood transfusion so that her anemic condition is improved, and the dyselectrolemia, like Dr. Surya had mentioned, IV fluids is something which is main and very important. Low molecular weight heparin might be a question for many because a patient is already bleeding. Why will you give heparin? But the answer is these conditions are very, very prothrombotic. And even if patient is oozing, we cannot afford to have conditions like DVT or pulmonary embolism in a patient like this. So low molecular weight heparin at a DVT prophylactic dose of 0.4 subcutaneous OD is mandatory in these conditions. Yeah. So we reassessed after 3 days of IV steroids. We've given steroids, but there's no clinical improvement. Patient continues to have bloody diarrhea almost more than 8 times per day. A better of the luck is the CRP and ESR tend to come down, but still not in the good baseline. Even after a blood transfusion, the hemoglobin kept falling. The counts kept elevating after the steroids. The platelets were stable. The dyselectrolemia were persisting, and the albumin started falling, showing a very, it's a bad prognosis in a way. So in this situation, the patient is alarmed. The doctor is alarmed. The drug is not working. Patient is alarmed that again, the therapy is not working. She's already been there in the hospital about 3 to 4 days. She's been evaluated. She has been biopsied, all these things, and the disease flare doesn't seem to come down. Yeah. So this is the time when you bring in, I'm a physician, but this is the time when you bring in a surgical cross consultation to give the option to the patient about a total proctocolectomy, because that will be the treatment of choice when you have a steroid failure. So day 3 of steroids, when we don't have a clinical response to steroids, so you should give the suggestion of a option of a surgical total proctocolectomy in this patient with an extensive colitis. So once the surgical options were given, the other options has to be given in a situation like a 2022, where cost is not a big issue for most of the patients, and patients should be given a medical rescue therapy with biologic agents. Biologic agents are immunomodulator drugs, which are large molecules which react with drugs, which react with the immune system with drugs like infliximab, adalimumab, cyclosporin, and tofacitinib. Patient was started on tofacitinib. This is a newer small molecule, which is an oral molecule, which is given 10 mg twice a day for 3 days. The patient was given for 3 days. And along with that, patient was continued on other hemoglobin and electrolyte corrections and things like that. Patient dramatically improved after 3 days, and the bloody diarrhea was completely stopped in 1 to 2 days. Yeah. This is the follow-up labs. CRPs are normalized, hemoglobin normalized, the albumin improved, patient, the electrolytes improved, and this is in a day or two, patient was discharged. So, but tofacitinib is a newer molecule. It's not very commonly exposed in the regular practice, but this is an oral molecule. This is not a subcutaneous or anything. It's an oral molecule, but always take care to rule out a latent tuberculosis by a CT chest or an TB NAT gold assay. Viral markers has to be ruled out. LFT lipid profile has to be monitored. ANA profile to rule out any other autoimmune disease has to be done. Any infection has to be ruled out. And if not, give under cover of antibiotics. Varicella vaccination has to be done when a molecule like tofacitinib, where there have been reports of fatal cases of severe varicella infection after starting tofacitinib. In an endemic country like India, varicella vaccination holds a very little meter, because most of us would have been exposed to varicella right in our childhood. But in dramatic cases, better to get the varicella vaccination sorted. This is a trial which showed the superiority and efficacy of tofacitinib compared with the placebo given for 8 weeks. The Octave 1 and Octave Sustain trial both gave a dose of either 5 mg or 10 mg twice daily, and significant remission was noticed in patients with tofacitinib of even 5 mg doses, and with 10 mg, the improvement was even better when compared to the placebo group. And the recent ECHO guidelines in 2022 gave a recommended therapy of tofacitinib to induce remission in patients with moderate or severe ulcerative colitis who are intolerant to conventional therapy. So patients who are not treatment expired naive to biologics, the recent guidelines still continue to use infliximab, adalimumab, vedolizumab, or tofacitinib over no treatment. So all the biologics are kept in one standard platform. So again, giving the advantage. But what is the big advantage of tofacitinib? Tofacitinib is a small molecule. One, it's not a monoclonal antibody. So there is no new antibody formation. No, all those things are less. There's extremely low cost. It costs around 6,000 rupees, but compared to other biologics, it's extremely cheap, cost effective, not the word cheap. Half-life is just 3 to 4 hours. It's very fast acting, and if planned for surgery, weaning off is extremely easy and fast. There are adverse effects of any drug, and tofacitinib is no exception. And we have seen documented cases of fulminant varicella, thromboembolism, hyperlipidemia, transaminitis, reactivation of TB and hepatitis B, neutropenia lymphoma, and lymphomas as a tumor form, even though rare, has been documented.